Hi, my name is Mary Vukisevich, and this video is about modifying the environment, including non-optical strategies and lighting. I would also like to acknowledge my content collaborators who are Kerry Fitzmaurice and Natalia Kelly. Here's a reference to a textbook which is authored by Scheiman and Whittaker, and it's a fantastic resource for low vision practitioners. And much of the information contained in this presentation can be found in this particular reference. Whilst it's designed to be a guide for occupational therapists, it is very useful for orthoptists too, as it's quite translatable to our profession as well. So how do we provide successful rehabilitation intervention? Well, sometimes patients don't actually respond to low vision intervention as well as you had expected. And this could be partly due to their vision or their vision loss, but it also could be due to psychosocial issues that we have raised earlier in some of the discussion topics in this module. Things like depression, coming to terms with sight loss, social support that they may have or may not have, home modifications that have been completed, their independence. These are all factors in whether they will be successfully completing a rehabilitation intervention. Studies have shown that in order to optimize a low vision intervention, you should actually start by educating the patient about their sight loss first and foremost. The physical cause of their sight loss, for example, if it's macular degeneration, and you let them know that it's the macula that's failing them, what the macula is responsible for, which type of sight, for example, close vision, vision for reading, colour vision, and so on. And then the functional impact, what tasks are going to be affected by the disease that they have. So again, if it's macular degeneration, the functional impact is that they have difficulty reading, they may not be able to recognize people's faces, their colour vision is affected, and so on. Devising an appropriate treatment plan for a patient is crucial, and Watson, whose reference I've put up here for you, suggests a 7-step treatment plan where teaching new skills comes after patient education. The importance of appropriate patient education has also been demonstrated for ophthalmic treatments, for example, for anti-VEGF therapy for neovascular age-related macular degeneration. So part of the treatment plan, as it says there, the 7 steps include education, telling the patient about their eye disease, prognosis, expectations from the low vision intervention, and so on. 2, offering therapeutic activities, for example, eccentric viewing training, scanning, which we're learning as part of this module, reading training. Step 3 is modifying the environment, so using size, contrast, colour, lighting, and glare to make changes to their everyday area to improve their functionality. 4, implementing non-optical devices. 5, using optical devices such as magnifiers. 6, offering computer technology, and 7 includes other resources. So in step 1, it's about modifying the patient's environment. And how do you conduct an environmental assessment for a patient? Ideally, what you want to be able to do is go into a patient's own home or their workplace or school or wherever it is that they spend much of their time, and your purpose is to find out what their setup is like. Do they have any hazards? Is the lighting good enough? What equipment or modifications currently exist at the location? So one important factor is to actually make things bigger. And using the principle of relative size magnification, you can achieve this. So if you double the size of an object, the angle it subtends on the retina also doubles. So for example, if your patient has difficulty reading N12 font, provide him or her with documents printed in N24 font, and this is a simple 2 times magnification following that principle. And also, this is the most useful for patients with just moderate vision impairment. So, for example, some things that you could do to make things bigger are provide large letters on a computer keyboard, offer them or explain to them how to make labels on food containers using larger font, suggest large print recipe books. You can also get measuring cups with large print values on them. You can get large print calendars or large print address books, and there's also large playing cards as well. So there's opportunity for recreation in addition. So you'll see a lot of these modified objects around with patients with low vision, but they can be accessed through the low vision agencies and in particular through an organisation such as Vision Australia. They have these resources available to patients. People with vision impairment often have difficulty with identifying colours. So for example, they'll have issues with pink versus yellow or blue, brown and black because they're very similar tone if you've got bad vision. So the principles of colour manipulation are, firstly, use bright colours, they're easier to see. 2, use lighting to increase colour visibility. And 3, colour is also a very useful warning cue. For example, identifying the edge of steps. You might put a yellow coloured strip across the edge of, say, grey concrete steps to help the patient identify where the edge of the step is. In terms of lighting preference actually varies from person to person, even if they have the same eye condition. So you can't say, okay, all people with macular degeneration need fluorescent lights, whereas all people with glaucoma need halogen lights. It doesn't work like that. So when providing lighting for your patient, you must also be aware of glare in addition to their lighting preference, because increasing lighting also increases the potential for glare. And of course, you need to try and avoid that for your patients because that causes light scatter within the eye and it affects their ability to see another object. So, for example, bright light or reflection from a window onto a TV screen is a source of glare. How do you minimize glare? Well, you use a directional light that has a shade, which you can see there in the picture with the girl reading. There's a shade. It's directional because it's positioned, the shade of the light and the light source itself is positioned directly on the book. It's not shining into her eyes. And of course, the light is positioned below her eye level. The preference is there to put the bottom of the shade approximately at chin height and ensure that the light is coming from the side. And that will help to minimize glare. The other thing probably to mention here is that the further away the light source, the duller the light is going to be. So the closer you put the globe or the reading lamp onto the book, the brighter that the book will appear. If you're evaluating lighting in your patient's living environment, a light meter can provide you with really good information about illumination. And the light meter measures how much light is actually bouncing off a surface and is measured in lux unit measurement. With this light meter, you can document whether there is sufficient lighting and justify the need for improvement. So you would observe your patient performing tasks such as reading, writing, activities of daily living in their lighting situation where they are at home, and then you would improve the lighting, make suggestions, and measure the difference between the two. Specifically using a light meter is not something that we would cover in this course. However, it's something that you should keep in mind if you find yourself working in a low vision environment. A light meter is going to be a terrific resource for you. We're going to move on now and have a look at the type of lights available for your patients. And of course, daylight is the one that comes to mind first and foremost. And this is the most natural source of light and is appropriate for most tasks. However, a side note is that it can be inconsistent, it can be glary, and it can also create shadows. The next type of light to consider is artificial light, and there are three main components of artificial light which are important to consider. The type of light, which we're going to explain further, either fluorescent, halogen, or LED, which stands for light emitting diode. So the amount of light that is emitted from the light source, which we call or is referred to as lumens, and this replaces the traditionally recognised watts, which is what used to be used to measure light, and that used to measure the rate of energy or power generated. So lumens is the amount of light that's emitted from the light source. So the greater the lumen, the brighter the light is, and that's what you can see on a box, on a globe box. And as I said, it used to be called watts, but now the correct reference is lumens. Another important component of understanding artificial light is something that we call colour temperature. And colour temperature refers to the colour of the light source, which is actually the wavelength of the light. And it can be what we call warm white, or that's generally a yellow tinted light, or it can be natural, which is similar to daylight, or it can be cool. The one on the right hand side is cool, the one on the left hand side is warm white, and the cool light has a blue tint to it. Something to note is that colour temperature is measured in Kelvin units. So continuing with our theme of artificial light, let's have a look at fluorescent lights. There are two types of fluorescent globes which are available. You've got the compact fluorescent light, or CFL globe, and that's on the left there. This is commonly used to replace the old incandescent light globes, which are no longer being used or produced. Compact fluorescent globes are most effective when used in a lamp. One thing to note though is that they do need warm-up time to reach their full luminance ability, because there are chemicals inside those globes which need to bounce around, and that takes time for them to heat up and become really bright. They're not generally recommended for light fittings to illuminate a room, so I wouldn't put one of these globes up in a ceiling because it's just too dull. They're much better in a reading lamp. Fluorescent tubes, which you can see on the right hand side, are more commonly recommended as general room lighting, and the benefit is that they illuminate a wide area and don't generally create shadows, and so they are also more energy efficient to run. When they're coming up to the end of their lifespan, they can flicker, and that means that the globe is about to blow and it needs replacing. Fluorescent tubes are also often used to illuminate large areas such as a workplace or classroom or library. So if your patient requires fluorescent lighting in the ceiling, it would be a fluorescent tube that should be recommended as opposed to a compact fluorescent light. A compact fluorescent light, as I mentioned, is better in a lamp. Another type of light, artificial of course, that you would be familiar with is the halogen light, and this produces a very bright light. One of the things that is an issue is that it can get quite hot, and this can be a danger for patients with vision impairment who might position the light too close to their face when reading. Because of the shape and size of halogen globes, the light that they produce is very intense, and they have a narrow beam angle, so the spread of light itself is quite narrow. Sometimes they can produce quite dark shadows, so you need to be mindful of where you're positioning the lamp for your patient and how you instruct them to position it. Halogen globes are commonly used for downlight fittings in homes, and they're commonly recommended for people who require concentrated lights on a task, for example, overhead lighting on a kitchen bench, which they would use for meal preparation and so on. You wouldn't necessarily recommend this in a reading lamp because of the issues that I raised before. They can be quite hot and a bit of a danger. And the final type of artificial light to discuss here is the LED, which stands for light emitting diode. And what it does is it uses a particular type of technology to produce an energy efficient light source. I'm not going to go into the type of technology, and it doesn't even matter for this course. LED lights do have a much longer lifespan than other types of lighting, and the benefit is that the light is bright and quite immediate. It's bright quickly. It doesn't take time to warm up, for example, such as a fluorescent globe. An LED light fitting itself is usually made up of multiple LED globes, and you can see that on the right hand side, and they can be made up as a traditional bulb in a tube, in a downlight globe fitting, or can be a strip of light as shown on the right hand side there. This type of light source is commonly the preferred choice when replacing or installing light fittings in a ceiling. Halogen lights are no longer being installed in ceilings in homes, and the reason for that is they just get too hot, and they are a potential fire hazard. So then, now that we know about the different types of light, natural as opposed to artificial, what type of light do we suggest? A study in 2007 by Epigesi and co-workers, which the reference is there, investigated reading performance with various lamps in patients with macular degeneration. Researchers agree that people with vision loss due to AMD show improvement in visual function with optimum levels of lighting because both visual acuity and contrast improve. Clinical experience shows that low vision clinics have several types of lamps available for demonstration to patients, and patients often ask which lamp is best for home use. So the purpose of the study was to determine if there was an objective difference in reading performance, and they used 4 commonly available lamps with different spectral radiances. So they had a standard or clear incandescent light, a daylight or blue incandescent light, a compact fluorescent, and that was in cool white, the compact fluorescent, and a halogen light. So the researchers chose to study patients with AMD because AMD is the most common cause of vision impairment, and research suggests that patients with AMD benefit from task lighting. And the researchers were actually interested to find out if there's a relationship between what's called spectral radiance and retinal scatter. So without going into too much more detail, the findings of the study indicated that there were no significant interactions between the type of macular degeneration that a patient had and the spectral radiance for any measures of reading performance. So what that means is that there were no differences between the lamps and any other outcome measures. The conclusion, as is written up on the slide there, is that the spectral radiance of localized light sources is not an important factor when deciding on the type of lamp to use for reading. So what that tells us is that it doesn't matter what type of light you suggest to a patient and what type of light they end up getting. What matters is that a light is used, and that will improve vision and contrast sensitivity. So obviously patients will have a preference, and it's good to offer choice, but any type of light is better than no type of light. The final things that I want to mention here are issues in relation to modifying contrast. So if your patient has reduced contrast sensitivity, then it's very likely that they have difficulty identifying contrasts of various objects when performing activities of daily living. you can provide advice about improving contrast of either the object that they're looking at or the background of the object of interest. And there is evidence to show that by increasing contrast between an object and its background, functional vision improves. So for example here, I've taken a picture of just some cherry tomatoes, and what I did was I placed the ones on the left on a red chopping board and I placed the ones on the right on a yellow chopping board. And you can see that just by changing the background, the contrast is quite significantly modified. Now, of course, you're watching this and I'm assuming, have perfect vision and you can see the tomatoes on the red chopping board. But if you've got reduced vision, it's much easier to see the tomatoes on a yellow chopping board. The same example is shown here but with a banana, and this image also shows how changing the background improves the contrast of the object of interest. It's much easier to see the edges of the banana when it's placed on a blue chopping board. Here's another example, and this image is of a staircase, and it shows that changing the contrast of an object can also improve visual function. So let's have a look at the picture on the left firstly. And what you're seeing is that there's a carpeted surface on the staircase, and then afterwards obviously they've done a renovation, they've removed the carpet and they've painted black and white steps, which are much easier to see the edge of. Now you're probably thinking, well look, the carpeted one's fine, I can see the edge, I can maneuver my way up and down those stairs, it's not that bad. But the image on the right, I've just reduced the contrast a bit, and this is how it might look to someone with reduced contrast sensitivity or with vision impairment, and all of a sudden the task is somewhat harder. And of course it's easier to maneuver up and down those black and white stairs than it is up and down the beige ones. So that concludes this video, and now you know how to consider a patient's environment, think about appropriate lighting in a given situation, and recommend modifications to colour and contrast.